and welcome to another enlightening episode of MedSynapse podcast series. I'm Hetvi Shah, your host, and today we have an incredibly insightful episode lined up for you. We're diving into the world of melanoma treatment, from early detection to advanced therapies. And as we all know that melanoma is a serious form of skin cancer, with the latest advancements in medical technology and treatment options, there is hope for better outcomes for patients. And to help us explore this important topic, we have with us Dr. Sopheaktra Thea, a distinguished dermatologist from Cambodia. Dr. Sopheaktra has extensive experience in skin health, having completed his master's degree in clinical dermatology and dermatology surgery from the renowned High Institute of Dermatology. He is known for his expertise in general dermatology, dermatologic surgery, and skin cancer surgery. So, welcome, Doctor, and thank you for joining us today.
Yes, and good afternoon, everyone. Thank you for having me today. I'm so excited to sharing my experience and knowledge to you all about the emerging early detection to advanced treatment in skin cancer, more especially melanoma.
Yes, thank you, Doctor. Same here. We are excited too. So now let's get started. So let's start by discussing the cutting-edge technologies currently being developed or utilized for the detection of melanoma at an early stage. So if you could share some insights on this with us.
Yes, please. Regarding to the question about cutting-edge technology current being developed and utilized to detect in early stage of melanoma, let's get a recap about what melanoma is. Melanoma is a deadly skin cancer without early treatment detection, and it can lead to death. Melanoma starts from a Greek word that combination from the mela, it means dark, and oma, it means tumor. Hence, it is like a malignant tumor originated from the melanocytes. And it can occur in any ethnicity of the group and also in any area of the body without or with substantial sun exposure. And we can find anywhere in the body that present the melanocytes. And for the risk factor of the melanoma, it is like frequently history of the sunburn or heavy sun exposure, like for the people, the general people who have the blue or green eye, blonde hair, red hair, fair skin. Sometimes they have more than 100 atypical nevi, typical nevi or atypical nevi, and also prior history of melanoma or family history of melanoma. And sometimes they can mimic with the genetic predispositions, like as they have the strong family history of invasive melanoma with or without pancreatic cancer. The genetic factor, environmental factor, including accessing of the sun exposure, UV-based artificial tanning contribute to develop of the melanoma. With the interaction between the genetic susceptibility and environmental exposure that illustrate the individual and inability to tan that fair skin and that sunburn that easily to have a greater risk to develop to melanoma. And according to the 2016, the estimated around 76,380 people diagnosed with melanoma, and around 10,130 will be dead in the United States. And with this higher data, from the 2002 to 2006, the incidence of melanoma continued to increase dramatically, and the overall survival rate, the overall rate of 33% for the men and 23% for the women. Melanoma increased in men more rapidly than the other malignancy. And based on the deadly rate is dramatically rising, and the early detection is recommended for general population. And the dermatoscope is the handheld dermatoscope is the useful one to detect the melanoma. And in November 2023, the Allegheny Health Network utilized the novel technology that might be useful to early detection in suspected melanoma. The name is Vectra WB 360. They use the 3D system to detect the whole body by containing the 96 camera and 96 flashlight. Actually, they use only 15 seconds to detect, to capture all the picture, all the mole, the whole body, and then they use the computer AI, artificial intelligence, to detect the mole that are very suspicious comparing to the baseline picture that we took. And based on the evolution of the technology in early detection of melanoma, first of all, they recommend the patient to use the self-skin examination. They have to know about themselves, what they are in the skin type, like the pediatric skin type 1 to 6, what they are in. They have the blonde hair, green eye, fair skin, more than 100 nail white in like a typical nail white, and they have to do the self-examination for detection skin cancer every 3 to 6 months. And then if they have the suspicion mole, they should visit dermatologist, the nearby dermatologist, to use the dermatoscopy examination on the suspicion area. And after that, the smartphone app, they are already utilized right now, and there are plenty app to use to measure and compare the evolution of the mole. We just take the picture and upload to the app, and then they can help us to analyze. And after that, the teledermatology may be useful for the remote area that they are like far away from the center that can detect melanoma.
Yes, thank you for sharing that. So technology is actually evolving with the ads that you told. Yeah. So now let's shift our focus to the treatment options. How have the recent advancements in immunotherapy, such as checkpoint inhibitors and CAR T-cell therapy, improved survival rate for melanoma patients?
Modernization of medicine and the revolution of medicine, they can improve a lot the survival rate of melanoma, more especially the stage 3 to stage 4. They can increase the survival rate of melanoma. And according to the cancer research in the UK, the overall survival rate, it depends on the stage of melanoma. For stage 0 to stage 1 in early detection and early treatment, they use the selection of treatment for more myographic surgery or wires excision. The overall survival rate after treatment in expectation 5 years or more, almost 100%. And in the stage 2 of melanoma, and the survival rate will be dropped to less than or around 85% for 5 years or more than 5 years. And for the stage 3, there is some specific point for the stage 3. Stage 3, there's drop to 70% for non-ulcerative melanoma patient with single nodule or micrometastatic, and will be less than 40% for the patient who have more than 4 or more lymph nodes in the metastatic. And in the 5-year survival rate, and for the stage 4, the distant metastasis have shown poor prognosis for the visceral and non-visceral metastatic. Prior the advancement of immunotherapy or checkpoint therapy. And the median of rate in the stage 4 is ranging from the 6 to 9 months, just 6 to 9 months. For 5-year survival rate will be less than 10% according to the lactate dehydrogenase abnormality elevated. And after that, approximately 70,000 7,000 deaths from melanoma predicted in the United States in 2021. But after developing the technology, medicine, and after developing the immunotherapy, around only 10,000 decreasing death, in those year predictable. And there are plenty type of immunotherapy. To understand the success rate of immunotherapy, it is important to differentiate between the different type available. That there are three main group immunotherapy that used to treat melanoma nowadays. For example, the checkpoint inhibitor, cytokine therapy, interleukin-2 therapy, oncolytic virus. And I just picked the checkpoint inhibitor to show the survival rate. For the patient who treat on the checkpoint inhibitor, namely ipilimumab, that published on 2015, research about the 12-pass study. The checkpoint found that on the unresectable area, that the area that we can't do the surgery for stage 3 or stage 4, the melanoma, it have increased 22% for who received this checkpoint inhibitor were alive for 3 years later. And then another one is nivolumab. The study also found that the treatment with this alone increased the change to survival compared to the previous one. When the investigator compared the treatment between two, for the people who and resectable area on the stage 3 to stage 4 melanoma, they found that people who were treated with this new molecule can survival the average about 37 months or 3 years, about 3 years, compared to the people who treat with the previous medication, which is ipilimumab, just 30 months. For after that, they try to combine these two molecules for the treatment in the advanced stage. The scientific report that the 6.5 year overall survival rate are rising up to 57% among the 314 patients. And all the research have to combine the medication to improve the survival rate. They have also found it causes more frequent serious side effects either than the one medication. Regarding to the anti-cytolytic T lymphocyte antigen 4, FDA just approved on 2011 for the advanced melanoma, show the overall response rate up to 20%. For the anti-program cell that ligand 1 inhibitor, this new medication, pembrolizumab, were approved by the FDA on 2014, and used to treat the metastatic malignant melanoma. They show the response rate up to 40%.
Yes, that is interesting numbers.
Yes.
And one more question before we go to actual question is, how can we prevent from going to from stage 3 to stage 4 or from stage 2 to stage 3?
It is like a hard questions because of there's many factors that interfere to detect the development from stage to stage. First of all, when you are suspected, you have the mole that according to the A, B, C, D, E, which is the A regarding to the asymmetry, B, border, irregulation, the margin, C, the coloration, will it change or not, D, the diameter, which is more than 5 millimeter, and the E, the evolution of the tumor, which is it grow or it bigger than before. You have to do the pan biopsy or the biopsy to confirm which is melanoma or not. If it is for stage 0, the melanoma in situ, we can do the treatment easily, and the overall survival rate is very high, and we can follow up. And then if we get through the tumor and it is already on the Breslow and Clark, which is the score that we detected from the biopsy, the dermatopathologist measure it for us. If it is the diameter, the deep diameter for this Breslow and Clark more than 1 to 4 millimeter, it will be jumped to another stage, and we have to do the body image to detect the metastasis, and we have to close follow-up with the dermatologist or oncologist to make sure that the tumor is not evolution. And for the lymph node, the sentinel lymph node, if we are suspected we have lymph node, the lymph node biopsy of fine needle aspiration and sent to detect the metastasis recommended.
Yes, that is interesting. Thank you for sharing that. Now, what are the emerging minimally invasive or non-surgical treatment options for melanoma, and how effective are they compared to traditional surgical methods?
Yes, regarding to the mode of treatment, comparing the non-surgical treatment and traditional surgical method, it depends on the stage of melanoma. It is uncomparable. At one, we got the suspect lesion tumor and we do the biopsy and we confirm it is the melanoma or the precancer lesion. The result gonna release if it is melanoma in situ and the Breslow and Clark less than 0.75. According to the depth of the lesion, because of it depends on the depth of the lesion penetrate inside the skin. The topical medication can be considered. It depends on the area that the patient have. For example, if the patient have a lentigo maligna, the lentigo maligna is normally developed on the face with this big lesion, and we cannot do the resection because of the cosmetic issue, and it's hard to repair the skin. We can try the topical medication. For example, the topical 5-FU, topical 5-fluorescein inhibitor, or imiquimod is recommended. At once the Breslow and Clark ranging from 0.75 millimeter to 1 millimeter, which or without lymph node detection, the area is resectable recommended. The surgical method is preferable by selection that what we have in our office. And if you can do the myographic surgery is one kind of method which is useful that can solve the margin and the cosmetic repairing for the patient. If we cannot do the myographic surgery because of lacking human research, because we need the dermatopathology in the office with us and they take it immediately after the surgery, and the wide excision is considering. The reason is to clear the margin and cut off the tumor in the early stage. So 5 years or more, overall survival rate will be high. And I'm gonna say that for staging to staging, nothing better than the resection, nothing better than the surgery if it can find in the early stage. However, in some subtype that we cannot do the surgery, like for example the uveal, mucosal, melanoma, and in the area that cannot remove, for the intralesional interleukin-2 oncolytic therapy, namely tamoxifen, laverivec, and the name is Imligic or TVIC, which is derived from the human herpes simplex virus to stimulate the immune response to kill the tumor cell. And another study have report about they use the BCG vaccine to use that to inject the intralesional. It can be considered for the treatment.
Yes. These options sounds promising.
Yes.
Now, however, we all know that there are always challenges in translating clinical trial results into real-world clinical practice. So, could you please elaborate on some of the challenges faced in this regard for melanoma treatment?
Yes, regarding to this question, by comparing the result in the clinical trial to the real world practice, I think the result in the clinical trial is not much different in the real world practice. However, there are some various factors that interfere the the target of consequence of the treatment. Like the cost of the treatment is very high. Some patient is like cannot afford for the immunotherapy for the targeted and even detected the gene that involved in developing melanoma. And the price of adjuvant treatment, systemic treatment, neoadjuvant therapy is like very expensive. Limitation of the treatment center. Not every patient have it close to the treatment center, by lacking follow up at the remote area. That's why we try to develop the teledermatology for helping people in that area. And some of the patients they neglect their health condition, like they didn't care about their health condition because of lacking knowledge related to the health conditions and lacking of human research. As we know that melanoma diagnosis and staging require multidisciplinary specialists, most especially the dermatopathology specialist. Yes, and the lacking of the limitation of doctor-patient relationship, because like some patients they have the limit knowledge to understand the advanced like the complicated phenomenon, the complicated immunology of the modernization of medicine. That's why the lack of the patient and also the lacking of the patient mentality support. And the important thing is the toxicity of the medication. Patient cannot like tolerate to the toxicity of the medication. That's why the result interfere, like comparing different from comparing to the clinical trial and real world practice.
Yes, that is rightly said. Now, let's talk a bit about future of melanoma. So, looking
Yes.
ahead, what are the most promising areas of research that could revolutionize melanoma treatment in the coming decade?
The advancement of melanoma treatment, they use like adaptive cell therapy. Adaptive cell therapy means the dendritic cell based on the vaccine that have ability, the hardness to select the natural killer of the cell. It depends on the cytotoxic T lymphocyte. It depends on the immune response and show the objective response rate from 8 to 15% in the overall survival rate, increased 20% on the melanoma patient. And this method, the tumor infiltration lymphocyte, the doctor start to cut the tumor, the one part of the tumor, and select the T cell lymphocyte from the tumor and increase the number of the T cell lymphocyte that recognition the melanoma. And then they used to infiltrate back to the tumor to make the tumor regression. There is the advancement. And then furthermore, the DNA vaccine, the vaccine of the melanoma, they already advanced on the fast. Right now, it is in the phase 2 of clinical trial, and right now they start to collect the sample size for the phase 3 clinical trial. The multiple antigen targeted or multiple cytokine insert into a single DNA vector induce the cell-mediated in humoral immune response. And the phase 2 clinical trial assess the effectiveness of the combination of intratumoral interleukin-2 gene and also the in vivo electrophoresis mediated plasmid deoxyribonucleic acid vaccine therapy they used to treat it. And currently, despite on the promising result from the targeted treatment from the BRAF gene or mitogen, from the mitogen activator protein kinase inhibitor, they used to treat, as well as the interleukin-2 interferon alpha treatment option in the metastasis are limited because of like the heterogeneity, the problematic of the patient satisfaction, and also the high genetic mutation rate. Recently, the role of epigenetic modification for the RNA in melanoma progress metastasis spreading been described. And the cyclin-dependent kinase 2A, the locus and the encode of the P16 gene, P14 gene, and by DNA methylation and not in the 27% up to 57% of the metastatic melanoma. And the enable of the melanoma cell to escape from the growth to arrest the apoptosis and generate by the ribosome protein in P53 pathway, the demethylation of this and other tumor suppressing gene with pro-apoptotic functions in the tumor necrosis factor related apoptosis induced linkage can restore the cell death pathway. So through this clinical study, it's gonna be the future clinical study in the melanoma variant.
That looks very promising. I hope that it goes success. So,
Yes.
lastly, from my end, I would like to ask one question that could you share how dermatology practice and melanoma treatments in your country, that is Cambodia, compared with those in other parts of the world, in your opinion?
And for comparing, we are walk behind them. We are lacking of many methods, even the technology in the targeted therapy, and then we also lacking of some gene detection. For example, as we know that the melanoma is related to many genes. For example, it can be associated with if we are chronic sun exposure induced damage, which is lead to DNA in the skin damages and unable to repair by grandfather gene, which is P53, and then it gonna be like the mutation of the gene. It gonna jump to the BRAF, and the BRAF we have the targeted treatment for those kind of. And another one is if it is like sun exposure induced, it gonna like jump to the KIT tyrosine inhibitor. So the immunotherapy gonna jump to this part. We are lacking of it. For the first treatment of our option is we suggest our patient come to detect in early, and we are normally found in the early stage of melanoma, and we try to do the Breslow and Clark. And if in case like there is more advanced, we will discuss with we already discussed with the oncologist, and then the oncologist gonna respond on the treatment. For the first thing that dermatologists in our country work is we treat only from the inside 2 to stage 2, which is like not present on the lymph node. The sentinel lymph node are free, no metastasis. If we found it is metastasis, it gonna be the responsibility of the oncologist.
Oh, thank you. Thank you for sharing that. That was interesting. So before we wrap up, I want to express our sincere gratitude for taking your time to share your expertise with us today. And it was truly enlightening to learn about the latest advancement in melanoma treatment.
Yes.
Thank you so much for sharing your.
Thank you. You're welcome.
Yeah. And to our listeners, we hope you found this discussion as informative and inspiring as we did. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, don't hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, take care and stay healthy.